ورحمة الله وبركاته. بسم الله والصلاة والسلام على رسول الله. معكم زميلي الدكتور علي العمراني، استشاري أول للأمراض السارية بقطر، ومحدثكم صلاح الدين القبلاوي، استشاري جراحة مسالك البولية ببريطانيا. نرحب بكم جميعا على موقع الاستشاري الطبي الليبي في هذا المنتدى الطبي بخصوص مرض كورونا المستجد. COVID-19 clinical diagnosis, prevention and management. We are all here to understand the basic clinical concepts about COVID-19. أولا نريد أن نعتذر عن بعض التأخير اللي حدث من الزوم لأنه they got new regulations, we have to start doing them while we are joining. We would like to welcome our panel of speakers. الدكتور هشام زقلام، استشاري أول للأمراض السارية بقطر. الدكتور سراج العوشار، استشاري العناية الفائقة بأمريكا. الدكتورة هالة بن حمودة والدكتورة آلاء الحبشي، أخصائيتان للأمراض السارية بمستشفى طرابلس المركزي. Also, we would like to welcome all our audience, especially those from back home in Libya, those young doctors who are in the front line facing the sick patients. We will start our meeting by presentations from our speakers, followed by any questions or comments from the audience. الآن أحيل الكلمة للدكتور علي العمراني، فليتفضل.
أهلا وسهلا بكم ومرحبتين. نتمنى كلكم تلقوا المفاعل هذه طيبة وكويسة وتستفيدوا منها. زي ما تفضل الدكتور صلاح، بعد الندوة الصغيرة في الأول عندنا 4 برزنتيشنز قصار إن شاء الله، بعدها في فرصة للتفاعل واستخدام خاصية Q&A questions and answers اللي في أسفل الشاشة. اللي معانا حاليا على زوم حيشوفوا في أسفل الشاشة Q&A، تقدر تدوس عليها تكتب أي سؤال. في بعد ما يكملوا زملائنا السلايدز الأولى اللي هيقدموها، أنا والدكتور صلاح الدين إن شاء الله حنقروا الأسئلة هذه، حنقدموها على الأخوة والأخوات ونحاول نجاوبوها بقدر الإمكان. كذلك بعد ما تنتهي الندوة على طول إن شاء الله حنبعث لكم تقييم على الإيميل، نتمنى جدا جدا أنكم تتفاعلوا فيه معنا وتردوا علينا، نبغى نتعلموا من التجربة هذه، نبغى نشوفوا عشان هي الجوانب اللي كانت كويسة ومفيدة وتناسبت مع طموحاتكم واحتياجاتكم، وشان هي الحاجات اللي كانت تحتاج تغيير أو تطوير، أو إذا كان عندكم أي اقتراحات للمستقبل جدا جدا نبغى نسمع منكم باش نعرفوا كيف نديروا الأشياء هذه بشكل أفضل وأحسن المرات الجاية. والآن نحولكم إلى زميلي الدكتور هشام زقلام. زي ما تفضل الدكتور صلاح في الأول وقدمه، دكتور هشام معروف لدى أغلبكم أعتقد، استشاري أول في الأمراض السارية، خبرة طويلة جدا جدا في هذا المجال، وحيبدأ هو إن شاء الله الكلام بخلفية على كوفيد، ومنها ننتقل إلى الزملاء الآخرين. مرحبتين بكم.
السلام عليكم ورحمة الله جميعا، وبارك الله فيك دكتور صلاح، دكتور علي، وباقي البانل for the introduction. طبعا I'm gonna start my talk to share. I'm gonna start it's gonna be a very short إن شاء الله محاضرة تكون قصيرة إن شاء الله. We're gonna be mixed English and Arabic. والغرض منها الحقيقة this lecture is just I think an open dialogue at the end for the questions. I'm going to start with this slide, and the slide is basically what's happened in the last 50 years. في نهاية ال50 سنة الأخيرة, just look into what kind of epidemics we have. If the worst epidemic, or the worst ones over the last 50 years, mainly viruses. But the reason I brought that slide or I brought this one, لما نلاحظوا سواء كانوا influenza, different influenza, starting for example from 2003 اللي هي بما تعرف بإنفلونزا الطيور H5N1، بعدين عندنا اللي هي other influenza اللي هو H1N1 اللي هي مسمى بإنفلونزا الخنازير. وطبعا before that in 1967 50 years ago كانت عندنا it's an epidemic happened from Marburg virus، والماربرغ معروف انه هو hemorrhagic virus. لو تشوفوا النمبرز of all epidemics كانوا it's not a major numbers، بس كان death is high. But let's look into this. لما نشوف الcoronavirus is before the new corona, which is 2019 new corona. We have two epidemics from the previous corona. The first corona was 2002, which is called SARS, and the second corona which we had in 2012, which was MERS. طبعا اعتقد احنا our experience with the previous corona خلتنا ان احنا we don't take this corona as we should be. لان لو تشوفوا SARS and MERS, it was localized in certain countries. SARS was in China and the country around, or MERS was in Saudi and the countries around, which is the Gulf area. لكن SARS and MERS, they're small in numbers, but the death can vary عالي. When we look into what we have this time, which is the Corona 2019, أعتقد إن Corona 2019 they learned from the relatives, other coronas. For this virus, which is the new virus, was completely different from the previous Corona one. It's very rapidly spread. Within a few months, a virus become in every country in this world, which is completely different from the SARS and MERS. Despite لو انك انت تقارن الفيروس اللي هو الكورونا 2019 مع السارس, there is some homology in 70 to 80%, لكن زي ما قلت لكم الفيروس هذا كان rapidly spread, unbelievably spread, even exceed the influenza viruses. والآن احنا نتكلم عليه more than 1 million case already recorded or confirmed COVID. ولو نشوفوا الأعداد الثانية اللي احنا we don't know about them, I think we're going to talk about tens of millions, if they are not hundreds of millions all over the world, with death is very high compared to any other viruses. This is just for the lesson we have to learn from what's happened over the last 50 years. I think we're going to have even more and more in the future, and we need to learn from this as a lesson. Okay, let's, there are two different names they use for the new corona or the new coronavirus. We're using SARS-CoV-2 for the name of the virus, and we use COVID-19 for the name of the disease. So that's why some people, they use COVID-19, some people, they use SARS-CoV-2. طيب, الvirus is a corona like any other coronas. And why they call them coronas? Because it's a very simple, small RNA virus covered with different proteins. But the interesting one, which is called glycoprotein spike S. وهذا هو فيه زي بيعطي الشكل الخارجي بتاع الفيروس, بيعطيه شكله like a crown أو زي التاج. And this is why we call them الفيروسات التاجية أو coronaviruses. وطبعا الglycoprotein spike S, and very important protein for the virus. And why is it important? Because this is the important for the virus to get into the cell. انت لو تشوفوا this slide, تشوفوا الفيروس how attached to the cell by this spike, which is the spike S. طبعا لازم الخلية أو important for the cell to have the receptors in it. والreceptors is called ACE2. هذا الreceptor, any cell which the receptor have, the virus can get into it. وإحنا نعرفهم from the mouth, even the tongue, up to down into the lung, the bronchial trees, as well as the GI, as well as the heart. They all have the cells with the AC2 on the surface. That's why the virus can spread into many places in our body. طبعا لو نشوف احنا what are the coronas we have 4 mainly corona called the human, وهذو كانوا مسؤولين على the common what they call common cold like symptoms, which we have them every year over the last many years. And we're not worried much about what you call it the normal corona infection of the human. But over the last 20 years, things have changed. The animal corona, which is mainly bat corona, managed to get into the human. طبعا by one reason to another, maybe we start, we have more interaction with the animal or animal products, whatever, it makes the virus to jump from the animal to the human and have a chance to change himself and adapt to live in our body. And as I said, we have now 3 different types of what you call the human animal coronas, which is SARS, MERS, and the last one is the COVID. طيب, what is the interesting about this virus? Number one, and that, as I said, this virus has learned a lot from the SARS virus. لأن if you look into that MERS, of the COVID virus, it starts shedding highly at the early stage of the disease. That's different from the SARS. SARS tend to peaks at the day 5. But هذا الفيروس at the beginning, of the symptoms, and even before the start of the symptoms, الفيروس level is very high. And that's why maybe the importance once you are exposed to the virus, perhaps you need to isolate yourself for 2 weeks before this. Once the symptoms maybe will start, at least you're not going to infect the others. And the other interesting thing about this virus, the patients might start shedding the virus 24-48 days. يعني 24-48 hours. يعني 1 day or 2 days. يوم أو يومين قبل طلوع الأعراض ممكن يبدأ المريض يعني زي ما يقولوا إنه هو shedding the virus. Other things طبعا الدراسات تشوف إن الفيروس can be isolated from the stool as well. We don't know what is the importance of that, and there is no evidence as yet. ما فيش أي أدلة يعني تقول إن the presence of virus in the stool has a significant to the perhaps to the spread the virus as yet. لكن على الأقل احنا we have to know إن الفيروس it can be isolated from the stool. الثاني حاجة which is important, the days of shedding of the virus, it varies according to what you call the symptom severity. البيشنتس اللي هم عندهم mild disease تلاقي إن shedding can go up to perhaps 12 days, but the patients who have the severe symptoms or severe manifestations, it can go even to 2 and 3 weeks. As well, we don't know, what is the values of these numbers at the end, for example, of patients when the symptoms have subsided. Patients still can shed the virus, but we don't know how much that's significant in spreading the disease. طبعا زي ما قلنا هذه هي النقطة إن حتى البيشنت لما recover from the symptoms ويصبح ما عنده symptoms, he is still positive as a PCR. What is the significance of that? What is the value of that in terms of the spreading of the disease? This is the days we need to come and studies. We need to know what is the importance of that. There is no age can be, escape from this. Everyone in this planet, no matter how old are you, it can be affected by the corona. So once you are exposed, the virus will have a chance to get into your body and you're going to be infected. And what you look into it, up to now, of course, the numbers going to change these numbers. تلاقي in the age between 15 to 49, those are the commonest group is going to be affected by the virus, but the death is going to be higher as older as you are. So if the more you are getting older, the chance of that is higher. This is up to now with the data we have. Maybe the data will change when we start having millions and millions of patients, but as I said, there is no exceptions in terms of age, and the death is higher once you get old. طيب طبعا الفكرة بتاع البروسيس of the infection in the COVID is similar like any other viruses. The pathogen we have this time, as I said, is called SARS-CoV-2. This is the name of the virus. You could put any virus here, but if we're going to apply this rule, so the pathogen is SARS-CoV-2. A reservoir, we don't know. Usually the viruses have the reservoir somewhere. Like, for example, MERS, we know the camel perhaps is the reservoir of that virus. But we don't know what's the reservoir of what you call it, SARS-CoV-2. There are many speculation. Some they said pangolin, which is a strange animal, and there are recent things. They said it might be big. So we don't know what is it as yet, but we'll leave it the reservoir as unknown as yet. They mentioned that the virus could survive on the surfaces, which we know, and we're going to say that later on in the lecture. And I said that perhaps the ventilation system as well could play a role, but these are as well, they are still not strong as yet. The portal of exit, so these viruses are going to come through the airways from the reservoir, perhaps maybe others from other places from the reservoir, and this is where the portal of exit then. And then, of course, when the spillover of the viruses happen, the transmission is going to come to the human, whether through the respiratory droplets or through the mucous membrane contact. This is the way how we're going to get the virus. And of course, once the virus gets in our body, it's going to goes into the airways. This is the main place where the virus likes, where he wants to attack the airways and the lung. But you need to remember, it can go to other places, and we start seeing some patients who might be presented with GI symptoms, maybe because of the virus is more there compared to the respiratory. Who's going to be affected? any individual. There is no exceptions. So if we talk about the 7 billions or 8 billions now on this planet, it can be affected if they're going to expose to the virus. So there is no exceptions. Of course, there are certain people who are at high risk compared to others. Let's say the old age, perhaps the patients who have a cardiovascular disease, or patients who are immune compromised, or patients who are diabetic. There might be at risk compare للnormal, but you take it anyone, it can be infected. So I'm going to now give a chance to Dr. Ala, who is a specialist infectious diseases, very bright doctor from Central Hospital. I know her very well, and she is going to tell us a little bit about the clinical presentation of COVID-19. Ala, it's yours.
Assalamu alaikum. Hello, everybody. Excuse me, Dr. Hisham.
Yeah, I have to stop share. Yeah.
Yes, please.
What? I don't see it. Where is it? Stop share. Yeah.
Okay, that's fine. Am I clear?
Yes, Doctor, you are clear. Carry on.
Okay. Assalamu alaikum. Hello, everybody. This is Dr. Ala speaking. I'm going to speak tonight about the clinical presentation of COVID-19. Regarding the signs and symptoms, and as mentioned previously by Dr. Hisham, the incubation period, it varies from 4 to 14 days, with average 5 days, but can be extended up to 24 days according to the recent WHO guidelines. And statistically, there is a suggestion revealed that 18% of the infected individuals will never develop symptoms. So, and around 80% will have mild symptoms, along with 20% will become seriously ill. And the case fatality rate, as mentioned by Dr. Hisham, considered low, around 2.5 to 4%, compared with MERS and SARS, as mentioned. This is the Diamond Princess cruise ship, which is represent a small community of the COVID-19 disease, where 20 crew of the members dealing with food started to show symptoms on 23rd of January and tested to be positive on the 9th of February. 10 days later, more than 700 passengers and cruise members out of 3,700 passengers ultimately tested positive for the virus. Surprisingly, that around 46% of them were asymptomatic at the time where they tested positive. Based on the Wang study from China, Wuhan, there was 138 COVID-19 cases. Only 36 of them were admitted to the ICUs. This study revealed that the fever and fatigue are the main presenting symptoms for more than 95% of the cases, along with cough and lower respiratory tract symptoms. The cough tends to be dry, but but sputum and hemoptysis also reported. It's worth mentioning that some atypical presentations, such as GI symptoms, confusion, chest pain, were reported, especially in the immune-compromised patient. There was another study from Europe, which is published by The Lancet, showing almost close data with fever and dry cough, fever and fatigue, and also lower respiratory symptoms, the dominant symptoms. Thus, fever, in addition to the fatigue, tends to occur on the first day, then followed by a lower respiratory tract symptoms in the next few days, progressively getting worse, reaching up the maximum at the end of the first week. On the week later, either the patient will gradually improve or will deteriorate more to need an ICU admission with a respiratory aid. The natural history of the disease tends to varies from 3 to 6 weeks duration. So the question now, when to consider COVID-19? The history is the cornerstone for suspected cases of COVID-19. Regarding the fever, cough, shortness of breath, recent travel to the endemic area, which is not applicable now, just because the whole world is pandemic, or the direct contact with the COVID-19 cases, family members with the symptoms, and healthcare workers. If you get 1/6, then the COVID-19 is unlikely. If it's 2/6, then further investigation, as Dr. Hala will explain more regarding the further imaging and further investigation, should be considered. If it's 3 or more, including at least one symptom, then the PCR should be carried out. So now let's talk about the first case in Libya, which is the index case, who is around 73 years old gentleman who got a background of diabetes and COPD. He had a history of travel to Saudi Arabia and Tunisia. He went from Saudi Arabia to Tunisia on the 5th of March, and he returned to Libya on the 12th of March. His symptoms 5 days later started. He presented with diarrhea and vomiting. The vomiting was once, and the diarrhea is more in terms of loose stool rather than true diarrhea. There was no fever at that time. A day later, he developed fever, fatigue, and worsening of his previous cough, since he's COPD patient. On 22nd, he was admitted, and the HR CT scan carried out, showing features of COVID-19, as Dr. Hala will explain more. And the PCR taken for him the first PCR sample was negative, and the second PCR sample there was a technical error. There was no human tissues, and the third PCR samples confirming that he got a COVID-19 or novel coronavirus. So the diagnosis of the first case in Libya was on 24th of March. It's worthy discussing the admission and discharge criteria for the patient. Hence, we are facing growing in the number for the time being. So, I'm really sorry for this crowded slide, but it just published a few days ago by the NICE guidelines. The striking thing here is they are depending on frailty score. If the patient more than 65 years old. So they are considering if the patient with high score more than 5 and the patient not improving with the initial management, so he considered for the end life care, which is let him die in peace. This is the most striking thing and different from the other criteria of admission. And let's keep the discharge criteria for more discussion. We may come up with specific discharge criteria. So please, doctors, be ready to fight COVID-19 by being smart, being safe, and being prepared. Thank you.
Sham, you need to unmute.
Thank you, Ala, for this. Well done, very good. Just stop, share your slides. Okay, you continue because Ala. It's privilege as well to introduce Dr. Hala. She's an ID specialist from Central Hospital as well. She's gonna talk to us about how to diagnose and what is the best way perhaps to reach the diagnosis, and to talk us a little bit more about the first patient in Libya. Hala? Hala? Unmute, okay. Hala, can you speak? Hala?
I think she's not with us, she's with the participant.
What's her username? Is it Ala E?
No, it's Hala Hamouda. Both of the usernames for me.
Okay, just give me a minute, I'll find her.
Okay.
Dr. Hisham, you can carry on if you want to, until we are ready for Dr. Hala.
There's only Hala without a surname. Is that her?
Yeah, it's
Yes, she said yes.
It's Hala E.
Did you get her, Ali?
Hello?
Yes.
Yes, Hala, yes.
Yeah.
Hala,
Hello. Salam alaikum.
Salamullah, we just introduced you and we said you are an ID specialist from Central Hospital, and you're going to talk to us about how could we diagnose a patient with the COVID and a little bit about what's happened with the Libyan patients.
Okay. I'm Hala bin Hamouda. Tonight we will talk about the investigation we need to in suspected cases for COVID-19, and it will be according to the criteria mentioned by Dr. Ala. To support or exclude the diagnosis, we need a laboratory and imaging studies. As we know, we have to start with some non-specific blood investigation. Here we need to highlight some laboratory clues regarding full blood count. Lymphocytopenia is present in more than 80% of cases, and surprisingly, leukocytosis is not a feature in the majority of cases. Other lab abnormalities include elevated LDH, deranged liver enzyme. In addition to that, elevated troponin, D-dimer, CRP may be predictors of severe illness.
Hala, are you with us?
Dr. Hala, are you still there?
Hala?
Ala, can you share the third slide, please?
It's already shared.
Yeah, just move the slide.
Yeah, it's working.
Hala, you speak. Can you speak, Hala? Hala? Can I back her up? Hala?
Yeah. So Hisham, I just checked. It looks like Hala is no longer online. I don't know if she's got problems with connection.
With Libya.
So do you want to continue from here, or do you want to go to your own slides?
Well, I think, I don't know whether maybe we'll continue. I don't know whether she will come back or What do you think? Well, as you like. What do you want?
I would suggest that we just stop from here and just,
Okay.
or if you can open the slides from your end.
Okay.
We will discuss PCR. There are already questions regarding PCR, so we can address those hopefully in the diagnostics.
That's fine.
So you can
Ala,
just go straight to your slides.
could you stop sharing, Ala? Right. I'll start. Yeah. I will start sharing myself. So this is where she stop, and this is, I think, perhaps is one of the important slides, and this is what we need to learn really, because if we think about two important things when we are dealing with the COVID up to now. Number one, it's a super fast spread of the virus. We've never seen such a virus spread like this way. So this is number one. And number two, we don't know whether there is other ways of this virus can spread through. We know that says through airborne droplets and these different things, but maybe how much could explain what we see, the number of patients we see every day. And the important aspect as well, if you think about what do we have up to now as a treatment, we don't have really much. But let me look into this slide. So see what will happen. So if you are really in coming contact with the patients who have a COVID, and if he's a sneeze or if he's a coughing, what will happen? He's gonna spread different type of particles. There are large particles and there are small particles. The large particle is gonna stick into our perhaps nasopharynx, oropharynx. This is the first place where the virus gets stuck there, and from there the virus is gonna spread to different parts. Of course, there are small particles, and usually it depends on the size. And we think the small particles tend to be less than 10 microns or even smaller. And those small particles, it goes directly into the lung. So whatever it's happened, and you come in within the zone of the patients. So what will happen? So if the patient is coughing, usually he could spread the particles up to 2 meters. If he sneezed, the evidence show it can really spread it up to perhaps 6 meters. And if he just talk, perhaps if he talking or whatever is shouting, whatever is happening, he might even throw it in front of him up to 1 meter. So you are within the zone of maybe, within the zone of the different kind of particles and sizes of the viruses. So what's happened after that? So when we have an infected individual and he's really sharing whatever he has, we're gonna get this virus by different ways. Either we're gonna have it as a small droplets hanging in the air, and we're gonna get it as a risk. We don't have the virus by airborne. So if those small particles in a hospital or perhaps in the crowded places and sitting or perhaps hanging in the air, we're gonna get them. That's one way. It's called airborne. If that as well, those particles, we get them through the droplets, and those droplets on the surface or anything, so the susceptible individual is going to as well get infected by those ones. Direct contact by the hand is a key way of transmission of the virus, and of course through the indirect contact, perhaps between patients and droplet, and as a susceptible individual. So these things we have to think of when we think of the virus and the different way of a spread. What we found that the majority of patients happened because of the close contact. They found perhaps up to 5-10% of patients get infection when you are coming in close contact with the patients. Interestingly as well, family cluster responsible the main way of the infection. And now لو تشوفوا ليبيا حتى هي الآن الفيرست patients ما احنا ما شفناش أي الحقيقة sample didn't find any people who have been in contact positive. لكن البيشنت اللي في مصراتة I think you've seen how many they are positive from the contact. وشفتوا البيشنتس اللي هو passed away as well, اللي هي passed away في TMC حتى هم اللي هم كانوا in contact with the patient. There are 4 positive from them just because of contact. And this is, I think, the family cluster account for the significant number of the transmissions. What about the secondary household attack rate is basically, I think, is a 10% at the beginning of the disease, but then with the isolations and the what you call social distancing, it become less percent to about 3%. What happened in the closed setting, perhaps in the nursing home, in the prisons? Yes, it's happening, and I'm sure it's going to happen, and it's happening. Maybe we haven't seen it in China data. We don't have it from there as an experience. But as I said, we're going to learn every day. We're going to see what's the Italian data, and now we're going to see other like Spain and UK data and other parts of the world. Schools, the transmission in school not observed because the school has closed. Most of the school all over the world has closed, and that's why we haven't seen any clusters happen in the school. Now, always the question is how long this coronavirus could live on the different services. And I should just show you the data of different services on how long it. The first one is copper. And interesting, the virus doesn't like copper and doesn't last long in there, few hours, and will disappear from it. But when you take something like a stainless steel, for example, most of the doors, they have a door. There are stainless steel stuff there. This is where the virus could last for many days, and it can last up to 3-4 days. They're sitting on the surface of it. And this perhaps may be one of the risk factor of transmissions, and that's why you need to be careful about what you call hand hygiene. Cardboard as well, it could last for perhaps 1 day or more, as well as the plastic. But the bottom line of this slide, the virus could stay on different service, perhaps up to 2-3 days, depending on the service, and depends on as well on the environment around that service. Very interesting data just came recently, and this is very interesting for us as a physicians as well. This just came in the Nature journal, and this is a study which is reviewed. What they said from this: surgical masks do a good business, good job, especially for the patient. So when you put the surgical mask for patient who have a COVID, it's gonna stop both the large particle and small particles into the great deal. So it's gonna get a nice protection by using the mask on the patient himself. Surgical mask is not N95 mask. It's just a simple surgical mask, which it's going to help us as well. I think I'm going to stop here now and give. And now I'm going to give the stage to Dr. Siraj El-Oshar, who is the emergency intensive care consultant, is going to talk to us about the managing patients with the COVID.
Assalamu alaikum.
Siraj, I'll share a screen. Just give me a second now.
Go ahead.
Yep.
Thank you very much, Hisham, who appreciate Dr. Ala, Dr. Hada, very well put and placed. Some of the points that have previously been mentioned, I'm just going to echo them. So basically, this is just a triage flow diagram. I guess I've been fortunate and unfortunate in some ways. نتعامل مع الحالات هذين لي حوالي 2 weeks plus, and أول ما صار الموضوع هذا فعلا يعني everybody كان يفكر كيف يتعامل معهن, ويبي يعرف بالضبط exactly where to go and how to isolate these people, وين نحطوهم, how sick they get, how fast they get that sick. As Dr. Ella said earlier, they usually develop acute respiratory distress within 8 days. I echo that number from a practical standpoint. ففي الأول كان في فوبيا كبيرة جدا من الحالات هذين. Where do we admit them? What floor do we put them on? Everybody was just so afraid. So it just happened that the ICU doctors in the beginning were the ones that we just found ourselves having to deal with them because everybody was just a little too cautious, I guess. So if you just have a patient from a triage standpoint and the patient presents to the emergency room staff are the most vulnerable from a healthcare perspective. لأن يحقوا المريض في الأول and they don't have any history. Basically he gets triaged based on the system that you work in. وحينحط في room ولا ينحط على كرسي. So لما يشوفوه في الأول they're not wearing anything, the suspicion becomes a little high. Based on the suspicion from the initial questions of history they get, the patient either goes to the regular floor, or based on his clinical presentation, he may go to a higher level of care. The main thing is going to be the hypoxia of what determines where they actually goes. Fever, cough, non-specific symptoms, those are just non-specific symptoms. The suspicion or the index of suspicion increased over a matter of 5 days because the geographical location of this disease changed dramatically very quick. So حتى نحن في الأول we were only putting people that had a travel history to areas of endemic proportions. لكن مع الوقت within a matter of 4 or 5 days, as I said, تغيرت الموضوع دي بسرعة. فقعدنا وصلنا لمرحلة anybody that is suspected, we just test him because it's already available in the community. If there is if there's no risk identified, there's no hypoxia, there's no need to keep the patient at home in the hospital. He can actually go home. Now, if for low, when we were taking a test and sending the patient back home, and we told him to do self-isolation, and as everybody knows, for العالم كله الموضوع هذا قاعد is very fluctuant because these people go home, some people don't have the ability to isolate, and they were being followed up on the test until we لأن ما وصلنا للمرحلة اللي وصلنا فيها توا. So overall, if the patient is high risk, and what defines high risk? As I said, the amount of oxygen. Usually, these patients, the high oxygen that we're talking about, I'm talking about 10 to 15 liters. من 10 إلى 15 لتر high flow oxygen. I'm not talking heated high flow oxygen because we don't like heated high flow oxygen. And there's a device that delivers oxygen very fast, a large amount. You can give up to 60 to 70 liters a minute at 100%, and it's humidified. It's more tolerable because oxygen at that high levels becomes very dry. It's very hard on the nose. It's not tolerable. When you get to levels that high, it has to be humidified. When it's humidified, that increases aerosolization. It increases the risk of infection to the healthcare worker that's there. So we do not recommend using that device on these kind of patients. We also don't recommend using a BiPAP or a CPAP because it's the same thing. So there's too much aerosolization and too much spread. So usually, by the time you get to 6-8 liters, it's about time you start being taken care of in a higher level of care. Whether you have an intermediate floor or an ICU becomes logistics, semantics. There's a level of care a little bit below the ICU, right? Whether انك تخلي المريض في ICU or تخلي في step down, it depends on the system and the facilities and the clinicians that you have taking care of that actual patient. By the time they get to 10 to 15, you have to look at his clinical appearance. We are leaning towards intubating these patients a little quicker. If there's any evidence of end organ damage, even if it's very limited, you have to be careful. If there's multiple comorbidities and there's other issues that are involved with him, you want to be very careful. And هذا أصعب سؤال, one of the hardest questions in medicine, right? When do you intubate the patient? I don't really have a great answer to that question. That's black and white. Use your clinical judgment. Use every piece of knowledge you have to evaluate the whole question. In one of the earlier slides, it was stated that multiple comorbidities, a patient that has too many issues, you even have to consider what we call comfort care, which is basically there are some people that if you commit them and put them on breathing machines, they are not going to come off. This concept exists in medicine. It is practiced in medicine, but given the scale وكمية الحالات اللي متواجدة في الموضوع هذا, it is becoming more prevalent on people talking about it. And it will وما يسهل النقطة هذه ما يسهل when it comes to making these kind of decisions. As we can see on the next slide, I'm just going to have a little chest X-ray. If you can move, Ali, the slides. Not every patient presents with this typical chest X-ray. As you can see, both of these patients are intubated. As you can see, both of these patients have bilateral infiltrates. It's clear that the patient on the left has a pacemaker device. So he's clearly older. He clearly has some heart issues. And you can guess that this guy has some comorbidities. On the case that's on the left, Clearly, there's a stent on the chest X-ray as well. So these patients have other multiple comorbidities. A chest X-ray is only a two-dimensional picture, so I can't see the 3D issues. So a lot of people are commenting on the CT scans. We're not getting routine CT scans on these patients because if you want to get a CT scan, you have to take off the isolation, لازم أطلع من الروom, you have to take them to the scanner, you want at least 2-3 people going with them, the patient is very hypoxic, you're running the risk of having problems and you're running the risk of exposing the patient to a lot of other patients. So basically, you only do a test once you have the confirmed diagnosis that is really going to impact your management. And point number one, these patients are staying on the vent a very long time. I do not have anybody that has been extubated yet, even though we haven't gotten 2 weeks. Point number two, these patients are requiring very high mechanical ventilatory support. I'm not going to say too much about the modes of the ventilation and what you do and what you don't do, but I will mention that we're proning them, which is basically you put the patient face down. There are a lot of ways to actually prone patient. There are a couple of devices and beds that help you do that. There's an easy way of doing it. You just flip him. Okay, all you need is manpower, and you just make sure that you pay attention to certain pressure points and how you keep his face, and make sure that you pay attention to the tubes and the lines that you actually use. So just to mention a couple of practical points, we'll see 1 or 2 points on the next couple of slides. As I said, high flow is acceptable, 10 to 15 liters maximum. If the patient seems to be clinically tolerating and does not have many comorbidities and you want to wait. There have been people that have been able to get over that. Okay? Be very careful. By the time it gets to day 8, day 10, you may have some problems and they can crash very fast with no warning signs. So perhaps it's not a bad idea to preemptively intubate this patient when he gets to a certain point. As I said, heated high flow increases aerosolization and it increases the risk to healthcare providers. And if you don't have healthcare providers to take care of the patients, you're going to have some problems. I would not recommend, as I said, positive airway pressure in terms of CPAP and BiPAP because there's a mask, it's not tolerable. Some of them start having some nausea and vomiting, and if he vomits in that sense, we all know what the problem is, and it's not going to be a quick turnaround. You're not going to be able to feed him. He's not going to be able to take any oral medications. You're basically creating a problem of management down the line. I would not recommend that. Now, when intubating these patients, how do you do that, right? What is the method? What is the practical points that I can share when it comes to intubating these patients? From my opinion, prepare everything you need in a cart and keep everything outside of the room. When you go into the room, make sure that you take the basics with you of what you actually need. There's more than one device right now to use to intubate the patient. A direct blade is not the best because it exposes you to the most amount of secretions coming from the patient's oropharynx. So there is a kaleidoscope, which is basically a blade. It's like very curved, and it has a wire plugged into a screen where you can actually see and other people see with you. The methodology and the way you use the that they've actually used it to put over patients, and it has holes that you can put your hands in. It's literally like an incubator for a baby, and the concept was taken from that. So basically, they put the shield over the patient, and you intubate him by having that shield over him, and you can serve. So when you have to intubate, you really have to make sure that you do it quick. So, as I said, everything barra dar jahza. You have a runner. You don't want somebody going into the room and going outside. If you need something, somebody من داخل الروم يطلع يقول لهم شنو يبي ويدوها له ويخشوا يعطيها لك, because you may have some airway problems, whether you're your bougie and your LMA and your disposable bronch and so forth. Okay, this way you're going to decrease the level of risk that you expose anybody inside, and at the end of the day, you need the actual airway. Next slide. RSI. There's a big debate that I don't think should be as big as it is in the critical care world of paralyzing a patient when you intubate him. Paralyze, please, because you don't have time and you don't want the patient moving his mouth and oropharynx and tongue. You need to get that airway quick, and these patients do not have. Very short, you have to get him intubated very, very quick. From my opinion, you give the sedation, whatever you want to use, Versed, etomidate, ketamine. You paralyze your patient and get that tube in him very quick. Another point from my opinion, I would place a central line immediately. I would not wait for later. You're going to give him some sedation. He's probably going to be on edge. There's a chance that his blood pressure is going to be low very transiently, and then you're going to end up giving him some fluid and he may bounce back. I would not wait for him to crash again or require a central line at a different time, because you're already in the room, you're already dressed up. Just go ahead and place a central line quickly. Obviously, what central line you place is going to be your preference, but do it quick. If you have an ultrasound, you're going to have to bring the device inside. You have to make sure that you clean it and you take it outside, and that's going to be a lot of limited supplies. A subclavian at this point, from my opinion, is the best central line, keeping in mind that they may be on high peeps, but at this point, it is what it is. You basically have to act pretty quick. As soon as you put the patient on the breathing machine, you have to evaluate his lung mechanics. Again, don't leave the room until you have the patient settled, because you don't want to be going in and out and seeing him again. He's already sedated. He's already paralyzed. Gas that quick, but at least if you have one, so some places are having a point of care blood gas. Now let's go to the previous slide still. Previous slide. Yes. So the one after that. Yes. So if you can get an ABG that quick and you can determine what the patient's PF ratio is, PF means PaO2 over FiO2 ratio. If it's less than 100, it's basically severe ARDS. Now, some people are defining that as below 150, and we know that ARDS in general is below 200, and anyway below 300 to 200 is acute lung injury. All semantics. All I'm using, or all we're using right now, is ARDS ARDS in that protocol. Put them on a low tidal volume ventilation, increase his rate as much as you are comfortable with. I've done up to 32, but usually they say 28 to 32. Make sure that you measure your pressures. I would commit to paralyzing the patient earlier until you can settle him down a little bit. And these patients respond very, very, very well to high PEEP. PEEP as high as 20, 22. Now, that basically will take a good 5-8 minutes at most. Playing with the breathing machine, looking at the pressure volume loops, looking at the flow volume loops, assessing his PEEPs, assessing his peak inspiratory pressures, his plateau pressure, and seeing what your optimal PEEP is. You can gauge that relatively quick. As you gauge that, you're going to establish your line and you're going to establish your access. Another maneuver that I found to be very helpful relatively quickly for about 40 seconds or 30 for 30 seconds. So people that practice intensive care medicine, it's not complicated. A simple mode of mechanical ventilation would help you achieve that. And every time you recruit, go up on your PEEP a little bit. Every time you recruit, you can go up on your PEEP a little bit. Keeping in mind that sometimes when you immediately do that, the oxygen level drops, and then it takes a while for the VQ mismatch to actually arrange itself so you get your actual pure numbers. Next slide. A preferred plateau pressure is going to be below 30, basic ABCs. Establish your baseline ABG if you can. As I said, I would paralyze the patient. Plus minus, think about it, what kind of paralytic you have. Nimbix is the best, cisatracurium. If you can only use PRN paralytics by giving it bolus doses, you're exposing risk to the actual healthcare professional going in, the nurse, but it is what it is. And we prone these patients. If after the first 4 or 5 hours, 3, 4, 5 hours of assessment, you're not getting good oxygen levels, you don't like how the patient is behaving, prone him. And I would prone him quicker. And when you prone, the Perceiva trial that recently was about 2013, 2014, that's the landmark trial that everybody's going about now. They were proning people for 24 hours. They were giving them about 18 hours, then flipping them back for 6. I think we prone these patients a little longer. If you have a lot of patients, and a lot of hospitals do, they have like 10 to 15 patients that are all prone. It takes a lot of manpower to prone people, and it takes a lot of time. And when you're going to be flipping him back and forth, some hospitals are even thinking of creating a team that's called a proning team, because they're just going to be going from room to room, proning people back and forth. Every time you prone a patient, you increase the risk of losing an airway, you increase the risk of lines being moved, and you increase the risk of everybody having to go into that room to deal with that. I've proned people as long as 3 to 4 days. I have no evidence, apart from the fact that I've had a good chunk of them do well. And why would I expose him when I flip him back to de-recruitment? Some people are making the argument that when you flip him back, you de-recruit, there's some benefit to that. There's no real evidence that supports that at this point. But when you keep him proned, you're definitely going to get a longer benefit of keeping him like that and exposing everybody to less involvement. Now, are there going to be some pressure sores on his forehead, on his shoulders, on the side, and his chin? Yes. But he's going to live through it. So you are going to have to make some hard decisions in terms of benefit versus risk of what the patient is going to have to be dealing with in the long term. Again, some of these patients go into renal failure. Next slide. Let's go to the next slide. The final common pathway when these patients get sick is the common final pathway of end organ failure. Whether it's septic shock or cardiogenic shock or hemorrhagic shock, there are problems here. There's up to 20% of these patients that are developing a cardiomyopathy, where their EF is like 10 to 15%. Use inotropes and pressors how you feel fit, okay? Acute kidney injury is very common in these patients as well. You can put them on renal replacement therapy, whatever device and equipment you have. You can do dialysis, even CRRT, to a patient while he is proned. You cannot put a catheter while he's proned, obviously, but you can dialyze them while they're prone. Just make sure that your catheter works well and the flow of your catheter is okay. Keep them dry. The last sentence on the second line, lungs are more important than kidneys. I diurese them until their creatinine starts to climb. And if their creatinine starts to climb and you have problems, put them on dialysis. And again, you're going to get into the basic ABCs of critical care medicine that involves feeding, nutrition, DVT prophylaxis, GI prophylaxis. And for the record, you can feed people that are paralyzed. Somebody that wants to talk about it at a different time, hopefully we can be available to talk about these issues. You don't have to fully feed him, but you can feed him. And there are scenarios where you want to decrease feeding and increase feeding based on their carbon dioxide production and what your vent is doing with you and all that stuff. So the rest just becomes basic critical care. Is there a role of antibiotics? Well, everybody is saying a superimposed bacterial infection is what causes these patients to actually crash. Sometimes that's true, sometimes that's not. You don't always have positive cultures on these patients. So if you want to commit to antibiotics, don't overdo it. If it's a 7-day course or a 10-day course, and our infectious disease doctor can probably comment on that, you have to commit to when you want to stop them, because you don't want to create a resistant strain by just doing them just because it's easy. And again, basic critical care 101. There are a lot of details في تفاصيل واجدة ممكن واحد ينسأل فيهن, and whatever we can do to help, إن شاء الله الكل يكون موجود يعني. Next slide. I believe that's it. And thank you.
Thank you very much, Dr. Siraj.